Hi, this is David McFeeters from the University of Illinois College of Medicine in Peoria. In today's video, I will be discussing 1-carbon metabolism and its importance in medicine. Although I feel this video contains all of the information you'll need to know about 1-carbon metabolism, I highly recommend the suggested readings shown below. Here are the learning objectives for this session that I'll let you read on your own. Please note that the upper right-hand corner of each slide contains the associated learning objective number or numbers. What is 1-carbon metabolism? 1-carbon metabolism is a series of interlinking metabolic reactions that include the folate and methionine cycles and the transsulfuration pathway. 1-carbon groups less oxidized than carbon dioxide are transferred between compounds by reactions involving tetrahydrofolate, vitamin B12, and S-adenosylmethionine. Tetrahydrofolate participates in a limited number of biochemical reactions, the most significant in medicine being the de novo synthesis of deoxythymidine monophosphate, which is essential for DNA synthesis, the de novo synthesis of purine nucleotides, and the vitamin B12-dependent remethylation of homocysteine to form methionine. Natural folates are abundant in many foods, including raw nuts, lentils, chickpeas, and leafy green vegetables, including spinach, lettuce, and broccoli. Synthetic or manufactured folic acid is added to many grain products to fortify these foods and to help prevent the occurrence of neural tube defects during very early pregnancy. Fortifying the food supply is the most efficient way to reach most women of childbearing age, and according to FDA estimates, the benefits of reducing neural tube defects outweighs the costs of fortification by at least 24 to 1. Folates exist in many similar but slightly different chemical forms, each with three major structural components: a bicyclic pteridine ring, para-aminobenzoic acid, and either a single glutamate or multiple glutamates joined by pseudopeptide bonds involving the gamma carboxyl group. Commercially available or synthetic folic acid contains a fully oxidized pteridine ring and a single glutamate residue. The pteridine ring of natural folates is usually found in a more reduced form. The enzyme dihydrofolate reductase reduces folate to dihydrofolate or DHF and then reduces DHF to tetrahydrofolate or THF using NADPH as a cofactor. Note that in the remainder of this presentation, the term folate will be used collectively to refer to either folic acid, DHF, or THF unless otherwise indicated. Natural folates, including those in humans, also contain a polyglutamate tail that aids in their cellular retention. The active coenzyme form of folate is tetrahydrofolate, abbreviated THF, and is shown at right. THF accepts 1-carbon groups at either position N5, N10, or both, and then transfers these 1-carbon groups to other compounds. The 1-carbon groups transferred by THF are shown at left and may be in several oxidation states, with formal, formamino, and methynyl groups being the most oxidized and methyl being the most reduced. The methylene group is at an intermediate level of oxidation. Note that the individual hydrogen atoms at position N5, shown in faded red, and N10, shown in faded blue, are not present in THF derivatives that contain substitutions at these positions. For example, the hydrogen atom shown in faded red at position N5 is present only in unsubstituted THF and N10 formal THF. The polyglutamate tails of natural folates must be removed by a jejunal brush border peptidase prior to the transport of the monoglutamate form of folate into intestinal epithelial cells by a proton-coupled folate transporter called PCFT. The need to convert natural folates into their monoglutamate form before transport makes commercial or synthetic folic acid more bioavailable than natural folates. PCFT is defective in a very rare condition termed hereditary folate malabsorption seen in infants. The onset of symptoms in this condition include failure to thrive and megaloblastic anemia, and usually occur a few months after birth as maternal folates are exhausted. Following import, folate is converted into polyglutamate forms, reduced to N5-methyl-THF, and exported into the interstitial fluid by the reduced folate carrier RFC. RFC is ubiquitously expressed and is the major folate transporter in mammalian cells and tissues. N5-methyl-THF is a very stable form of folate and the form most often found in cells and tissues. The liver takes up much of the folate from the portal circulation and stores enough to last for about 3 to 4 months following complete dietary cessation. This makes folate deficiency especially rare in developed countries where fortified foods are available. Conditions affecting intestinal folate absorption include its most common cause, excessive alcohol intake, Crohn's disease, and celiac disease. This figure shows an overview of the reactions involved in 1-carbon metabolism. I would like to focus on just the central portion of the folate cycle to begin our discussion of 1-carbon group transfers facilitated by tetrahydrofolate. As described previously, dihydrofolate, or DHF, is reduced to tetrahydrofolate, or THF, by dihydrofolate reductase. THF may then react with formate, circled in red, that is produced during the catabolism of tryptophan, as well as the metabolism of the toxic alcohol, methanol, to produce N10-formyl-THF, which is essential in purine synthesis, as shown in the next slide by the blue arrow in the diagram at left and in the reaction scheme at right. The carbon atoms of N10-formyl-THF are incorporated at both position C8 and position C2 of the purine ring of inosine monophosphate. The substrate for the second N10-formyl-THF requiring reaction, 5-amino-imidazole 4-carboxamide ribonucleotide, or ACAR indicated here, will be important later in this presentation when we discuss the use of methotrexate to reduce inflammation in rheumatoid arthritis. N10-formyl-THF may also be dehydrated to form N5-N10-methynyl-THF that is also produced in the catabolism of histidine, as shown at right, where histidine is first deaminated to produce urocanic acid and then is converted in 2 steps into N-formamminoglutamate, or FIGLU, which reacts with THF to form glutamate and N5-formamino-THF, which is then deaminated into N5-N10-methynyl-THF. Importantly, when there is insufficient tetrahydrofolate available, excess N-formamminoglutamate, or FIGLU, is excreted in the urine, and this is a diagnostic sign of folate deficiency if it occurs after a test dose of histidine is ingested. N5-N10-methynyl-THF is subsequently reduced in an NAD pH-dependent reaction to form N5-N10-methylene-THF. N5-N10-methylene-THF is also produced in the synthesis of glycine from serine, as highlighted by the gold arrow in the figure at left. Serine is a non-essential amino acid derived from the glycolytic intermediate 3-phosphoglycerate. As shown at right, THF accepts the methylene group from serine to produce N5-N10-methylene-THF, glycine, and water in a reaction catalyzed by the vitamin B6-dependent enzyme serine hydroxymethyltransferase, abbreviated SHMT. Because this conversion of serine to glycine is readily reversible, glycine can be reconverted to serine by drawing carbon from the 1-carbon pool. 1-carbon group transfer by THF is also essential for the synthesis of deoxythymidine monophosphate, as shown by the pink arrow at left and in more detail at right. N5-N10-methylene-THF is converted to DHF during the methylation of DUMP to DTMP, and this illustrates how folate is absolutely required for DNA synthesis. As one might expect from the many roles of folates in metabolism, folate deficiency impairs cell division, particularly in rapidly growing cells, by inhibiting DTMP synthesis from DUMP, specifically inhibiting DNA synthesis. Folate deficiency also decreases purine synthesis. Decreased nucleotide levels also interfere with the repair of DNA damage. The inhibition of DTMP synthesis results in an increase in the intracellular levels of DUMP, and this increases the incorporation of deoxyuridine into DNA. Deoxyuridine is normally rapidly removed from DNA, but if it is not replaced due to a lack of thymidylate, it results in DNA fragmentation. The classic clinical presentation of folate deficiency, as well as that of vitamin B12 deficiency, because it creates a functional folate deficiency, as I will explain shortly, is megaloblastic anemia. In megaloblastic anemia, defective DNA synthesis leads to unbalanced cell growth and impaired cell division, causing bone marrow to produce unusually large, structurally abnormal, immature red blood cells, as shown below. These immature red blood cells have an increased mean corpuscular volume, or MCV, of greater than 100 femtoliters compared to a normal MCV of 80 to 95 femtoliters. The spleen normally removes such megaloblasts when they reach the peripheral circulation. Folate deficiency also affects other hematopoietic cells and results in the appearance of hypersegmented neutrophils in the peripheral circulation, as shown at right. Folate deficiency may also result in glossitis, which is a condition where the tongue becomes inflamed and swollen, making it appear smooth or glossy, and this results from the defective replacement of damaged papillae. Glossitis may also result from other causes such as allergies, infections, or iron deficiency. Folic acid metabolism is often targeted in cancer treatments to inhibit the rapid growth of cancer cells. Dihydrofolate reductase, or DHFR, is essential for generating THF from DHF and DHF from dietary folates. As shown below, methotrexate is a structural analog of folic acid, termed an antifolate, and is a competitive inhibitor of DHFR, binding about 1,000 times stronger than folate. High doses of methotrexate inhibit rapid cell growth in cancers, such as acute lymphoblastic leukemia, breast cancer, osteosarcoma, and advanced non-Hodgkin's lymphoma. N5-formyl THF, also known as folinic acid and sold commercially as a product called leucovorin, is a natural storage form of folate used as an antidote to the harmful effects of methotrexate on healthy cells because it bypasses the need for activation by DHFR. This effect is often called leucovorin rescue. Low doses of methotrexate are commonly used to reduce inflammation and ease the symptoms of rheumatoid arthritis. Methotrexate promotes the intracellular accumulation of the purine biosynthetic intermediate, ACAR, as previously noted, and this leads to the increased release of adenosine, which has potent anti-inflammatory effects at sites of inflammation. Vitamin B12 connects the folate cycle to the methionine cycle. N5-methyl-THF is produced from N5-N10-methylene THF in an irreversible NADH-dependent reaction by methylene tetrahydrofolate reductase. The methyl group, shown below in purple, is derived from either serine or N5-N10-methynyl THF and is first transferred to vitamin B12 and then to homocysteine to form methionine by methionine synthase. Following the formation of methionine by methionine synthase, methionine reacts with ATP to form S-adenosylmethionine, or SAM, in a reaction catalyzed by methionine adenosyl transferase. SAM then acts as a methyl group donor in the synthesis of many compounds that contain added methyl groups, as detailed in the next slide. In the first example, S-adenosylmethionine reacts with norepinephrine to form epinephrine. During phospholipid synthesis, methyl groups from 3 S-adenosylmethionines are added to phosphatidylethanolamine to form phosphatidylcholine, a major membrane phospholipid. S-adenosylmethionine also functions in the methylation of DNA and histones, thus playing a critical role in the epigenetic regulation of gene expression. More than 35 reactions in humans require methyl group donation from SAM. Following the transfer of the methyl group from S-adenosylmethionine to other substrates by various methyltransferases, S-adenosyl homocysteine is formed, which is then hydrolyzed to produce homocysteine. Homocysteine is then either remethylated to form methionine or condensed with serine to form cystathionine by cystathionine beta synthase. Cystathionine is then converted to cysteine and alpha-ketobutyrate by an enzyme called cystathionase. Feedback inhibition of cystathionine beta synthase by cysteine keeps methionine from being used for the synthesis of cysteine unless the levels of cysteine in the body are lower than that required for its metabolic functions. This spares methionine, an essential amino acid. The liver also contains a second minor pathway, not found in other tissues, in which betaine, derived from choline, can donate a methyl group to homocysteine to form methionine and dimethylglycine. Homocysteine, the oxidized disulfide of homocysteine, is not efficiently reabsorbed by the kidneys, and this may result in homocystinuria when homocysteine metabolism is impaired. The major route of homocysteine metabolism is by its vitamin B12-dependent remethylation to methionine, but it may also be used in the trisulfuration pathway, as just discussed. Accumulation of homocysteine results in homocystinuria and may occur in deficiencies of either vitamin B12 or folate or methionine synthase deficiency, as well as severe vitamin B6 deficiency. Mutations in cystathionine beta synthase are the most common inherited cause of homocystinuria, and this is termed classic homocystinuria. Treatment of classic homocystinuria may involve increasing residual enzyme activity by giving paroxetine, or vitamin B6, to those patients with vitamin-responsive variants, reducing the load on the affected pathway with a low methionine diet and supplementing the diet with cysteine, or giving betaine in order to utilize the alternative hepatic pathway to remove homocysteine. This slide shows the clinical characteristics of classic homocystinuria caused by cystathionine beta synthase deficiency. These include vascular abnormalities characterized by thromboembolism. As shown in the graph, increases in total plasma homocysteine directly correlate with cardiovascular mortality. Cystathionine beta synthase deficiency may also cause a displacement of the lens of the eye, called ectopic lentis, or cause severe myopia, as well as developmental delays or intellectual disabilities, as well as brittle bones that are prone to fracture or other skeletal abnormalities which are similar to those found in Marfan syndrome. Mutations in cystathionase result in cystathionuria, a pathologically benign condition that can be treated with supplemental vitamin B6. Folate deficiency during early pregnancy has been associated with an increased risk of neural tube defects in the developing fetus. This risk is significantly reduced if women take folic acid supplements before and following contraception. The increased risk of neural tube defects were first observed in women with a temperature-sensitive variant of methylene tetrahydrofolate reductase who showed low levels of N5-methyl-THF and increased levels of homocysteine. These women were also deficient in folic acid, and it was suspected that the resultant inhibition of DNA synthesis may cause the neural tube defects. These observations resulted in the recommendation that women considering pregnancy begin taking folic acid supplements prior to becoming pregnant. This also led to the supplementation or fortification of flour-containing products with folic acid, as many women are often unaware they are pregnant before missing their first period following conception. Mothers consuming supplemental folic acid before and during pregnancy can prevent 50 to 70% of all neurotube closure defects. Neural tube closure occurs around 23 days post-conception. The neural tube closure defects, NTDs, in particular, spina bifida and encephalopathy, are among the most common severe congenital malformations associated with folate deficiency during early pregnancy. Spina bifida, as shown at top, often results in lifelong disability and may necessitate multiple surgical interventions, while encephalopathy, as shown below, is incompatible with postnatal survival. The exact metabolic mechanisms underlying the pathogenesis of folate-responsive NTDs has yet to be uncovered, but in addition to a decrease in DNA synthesis, folate deficiency may alter membrane phospholipid biosynthesis, reduce the levels of neurotransmitters, or result in hypomethylation of DNA, which could result in alterations of gene expression, including increased expression of certain microRNAs. To finish the discussion of one-carbon metabolism, I would like to return to the first learning objective and discuss the sources, structure, and functions of vitamin B12, also known as cobalamin. Vitamin B12 is produced only by bacteria. The major dietary sources of B12 are meat, eggs, dairy products, fish, poultry, and seafood. Enough B12 is stored in the liver to last 3 to 5 years if a person stops consuming vitamin B12 containing foods. This puts vegetarians, vegans, and some elderly patients particularly at risk for vitamin B12 deficiency. Vitamin B12 contains a core and ring system coordinated to a cobalt plus 3 atom similar to the iron plus 2 atom in heme, and this cobalt can form a weak bond to a carbon atom, either a methyl group in methylcobalamin, which is used in the methionine synthase reaction, or with the 5' carbon of deoxyadenosine in 5' deoxyadenylyl cobalamin, which is used in the methylmalonyl-CoA mutase reaction that I'll discuss shortly. Cyanocobalamin is a man-made form of B12 found in supplements where the cobalt atom is bonded to a cyano or cyanide group. I would like to return briefly to how vitamin B12 connects the folate and methionine cycles and illustrate where B12 fits in with the irreversible reactions of the folate cycle shown here by the red arrows, pointing out in particular how the methylene tetrahydrofolate reductase reaction is irreversible. In severe vitamin B12 deficiency, N5-methyl-THF is trapped because it cannot be converted back into either N5-N10-methylene-THF or converted into THF by the B12-dependent methionine synthase reaction. Thus, B12 deficiency creates a functional folate deficiency. This is known as the methyl trap hypothesis and illustrates how a severe vitamin B12 deficiency, like folate deficiency, may result in megaloblastic anemia. This slide outlines the intestinal absorption of vitamin B12. Ingested vitamin B12 can exist either free or bound to dietary proteins. If the ingested B12 is bound to dietary proteins, it must first be released from these proteins by the action of the digestive protease pepsin in the stomach. Once B12 is released from any bound dietary proteins, it then binds to a carrier protein known as transcobalamin or R binders. In the small intestine, pancreatic proteases digest the R binders, and the released B12 then binds to an intrinsic factor which is secreted by the parietal cells in the stomach. The intrinsic factor B12 complex then attaches to specific receptors in the terminal segment of the small intestine, or ileum, after which the complex is internalized. Following internalization, it is carried in the blood by a protein called transcobalamin 2 to the liver or other tissues. Without intrinsic factor, any unabsorbed B12 is excreted in the stool. Pernicious anemia is a relatively common problem that is caused by the malabsorption of dietary B12, usually from an age-related decline in the production of intrinsic factor or the production of antibodies that attack and destroy parietal cells, or a decreased ability of parietal cells to secrete sufficient acid, which leads to a high intestinal pH, as well as partial resection of the stomach or ileum or pancreatic insufficiency. Normally, pernicious anemia is treated with intramuscular injections of B12 or high-dose oral B12 supplements. In addition to the megaloblastic anemia caused by trapping of folate as N5-methyl-THF, severe vitamin B12 deficiency may also cause irreversible neurological symptoms, including symmetric numbness and tingling of the feet, diminished vibratory and positional sense, progression to a spastic gait, or neuropsychiatric manifestations such as memory loss, depression, etc., and in some cases also causes auditory and visual hallucinations termed megaloblastic madness. What causes the neurological symptoms of B12 deficiency? In addition to the methionine synthase reaction, vitamin B12 is required for the conversion of L-methylmalonyl-CoA, resulting from the metabolism of homocysteine, branched-chain amino acids, and odd-chain fatty acids, to succinyl-CoA by methylmalonyl-CoA mutase. Severe vitamin B12 deficiency results in the accumulation of methylmalonyl-CoA, causing methylmalonic acidemia. If methylmalonyl-CoA is used in place of malonyl-CoA during fatty acid synthesis, it results in the formation of methyl-branched fatty acids. When the methyl-branched fatty acids are incorporated into the lipids of the myelin sheath that surrounds nerves, it leads to their destabilization, eventual neuron loss, and the onset of neurological symptoms. Because the neurological symptoms of B12 deficiency are irreversible, it is very important to assess vitamin B12 levels in patients with megaloblastic anemia and not simply treat them with supplemental folate. Are there potential dangers to taking excess folate or vitamin B12? Well, as we just discussed, taking large amounts of folate supplements may mask a vitamin B12 deficiency because these supplements will correct the anemia that B12 deficiency causes, but not any permanent neurological damage. Folate that is naturally present in foods is not harmful. However, one should not consume folate in supplements or fortified foods in amounts above the upper limit of 1,000 micrograms per day. High doses of folic acid may accelerate the progression of preneoplastic lesions, increasing the risk of colorectal and possibly other cancers in certain individuals. Excessive amounts of folate and B12 during pregnancy may also increase a baby's risk of developing autism spectrum disorder. And finally, it's been recently reported that high levels of B12 may be associated with an increased risk of early death. In summary, tetrahydrofolate facilitates the transfer of 1-carbon groups required for the synthesis of purines, thymidine, glycine, methionine, and S-adenosyl methionine. Folate deficiency affects fast-growing cell types, resulting in megaloblastic anemia, and may cause neural tube defects during early pregnancy. Accumulation of homocysteine may result from several causes and has adverse health consequences. Vitamin B12 functions in just 2 reactions in the human body, the methionine synthase reaction and the methylmalonyl-CoA mutase reaction. Severe vitamin B12 deficiency leads to a secondary folate deficiency, resulting in megaloblastic anemia, but also causes irreversible neurological symptoms not seen in primary folate deficiency.